Good morning to you all. I think I am, I wanted to really come and attend this conference, but yesterday I could not come because I was on the airport for 7 hours and then my flight got cancelled. But I think I would like to really apologize for that and I would like to give you this video talk. Uh, the talk the conference has been organized very well and I'd like to congratulate the whole team of Yutha as well as Kowai Medicon and my friend Dr. Imanshu Pandya, and of course my own KEM hospital unit. Now, if I ask you what are these actually, then I'm sure you will know what these are. Some of you must have really seen this, but these are from California. These are redwood trees. These are so tall and thick that you can see there is a car which can go under that particular tree. Now, in spite of such a tall tree is compared to a small tree and then a tall building, and these trees are much taller than that, and there are jungles and jungles. And there are a lot of storms which really happen there. But in spite of that, tall trees with short roots, they still do not get uprooted in the storm. And what is the reason why they don't get uprooted? So they have a very strong network of each other, and they really have wonderful kind of trust in each other. So communications and network is something which I think we all of us should really understand. So important in our life. Secondly, I would like to give another example: plumber A versus plumber B. Now, plumber A out of 10 jobs does 7 bill. He cannot do, but tell you clearly, and there is no manipulation, and he will tell you that I can do this very well. Plumber B, out of 10 jobs, all 10 are done, but manipulates in such a way that you have to call him after 2 months for the 3 jobs which you have done. Whom you will choose, plumber A or plumber B? Because this is something which you have to really decide what kind of a plumber you really want. So that brings us to the fact that honesty, competence, communications, and network are all essential for a health professional. And that brings to our topic of professionalism today. Now, professionalism has to be a core competence. So we don't teach it so easily. And for many years, we were only following our role models. But professionalism has to be a core competence, emphasizing attitudes, values, behaviors, ethics, and commitment to lifelong learning, as well as the practice, patient care, safety, professional identity formation. And so there are many challenges to the whole thing. First thing, we have tremendous cultural variations. Professionalism is a hidden curriculum. It is never taught, and the lack of consensus on tools and sustainability. There's so much of variability and subjectivity, and this needs a longitudinal assessment. Having said that, how do you take this challenge? So we have to understand the no professionalism, analyze options, take action, assess the situation, and identify options. So that's what I'm really going to do today to take you through this professionalism assessment. The first question comes to you: how do you develop attitudes and values in a medical student or a doctor? Now, there is a developmental curve from novice to the expert. So, usually it begins with the conflicts, value conflicts, patient conflicts, then you have unmet deficits, time pressures, and then you have novel situations through which you go through this developmental curve, and then you start learning this. So health is a wider than the medicine, and you need a much wider vision, because there are same patients who have the same pathology may have a different solutions because of their other things are different. So Sushruth also said, the great Sushruth surgeon, a person who studies only one branch of science cannot arrive at a proper conclusion. Therefore, a physician should try to learn as much as related to the science as possible. Having said that, this was we tried to include this as I mean, I remember this was the first time in Indian curriculum we tried to include this ATCOM, attitude, ethics, and communication, which included not only knowledge, skills, and attitude, but it also included ethics, communication, values, and responsiveness. And this was the first time we tried to do this. So when we did it, it was the first time professionalism was introduced in the kind of a system. We tried to develop modules. I mean, the modules were developed in a structured graduate medical education. All of you are aware of ATCOM, so I won't really point to it. And what we did, we tried to customize the modules to our settings. What is Indian settings? I'm sure there is a differences in India culturally, but we tried to look at them that whether they will fit into an Indian situation. A vertical implementation across the curriculum. So what we thought, it has to be a longitudinal curriculum. It can't be done as one session. It has to be done repeatedly to develop the personality and professional identity of our students. Now, milestones are something which came along with that, and then there were many competencies which came in USA somewhere from 2012, and now is the milestone 2, where you start see how the student really learns. So, give you an idea what is ascendancy of attitude. That means, for example, you have to see facilitating a patient or family involvement. So, initially, it is closed questions, negative talk, then partnering skills, patient education, and that's the way it begins with. But when it starts, over a period of time, then the person starts talking positively. He understands patient's needs, and then he starts talking over a period of time. In fact, if you look at milestone 1 to 4, it's like trustworthiness, ability to level of what kind of a level of knowledge you develop. So it lacks knowledge, skills, and necessary to assign the task to you. Then you start demonstrating your clinical task to participation, which is passive. And then slowly you have some sufficient knowledge, but incomplete knowledge to function at a level to be assigned as a consultant. And then over a period of time, you have ability or level of knowledge, skills, attitude to achieve expected performance in a context of practice without direct supervision. So once you map your trustworthiness, it becomes very useful for the assessment. So same way, based on multiple milestones, became an intestable professional activity. So having given you the framework of professionalism, there are always issues about assessing a professional. And the topic as you given me is measuring the unmeasurable. Professionalism was considered to be unmeasurable. But let's see how we can really think about it. Now, when you start assessing a professionalism, it can be difficult. It's not so easy. It is not clearly defined. It's hard to assess when done well or poorly. It's like principle like honesty, difficult to operationalize exactly what it means and how to apply it in a given situation. Honesty. How do you really judge honesty of your students? All of them behave in front of you very well. How do you really know who is really honest and not honest? Issues of professionalism considered issues of character. We come to know these characters over a period of time. Personality, traits, not issues of behavior also. And lapses occur in good people acting in difficult situations. I think this is something which we also have to think. There are difficult situations when good people also act differently or they miss. That doesn't mean they are professionally bad. It's just a question of error that has happened. So what are the various issues while assessing? First thing, subjectivity and vagueness. There is a lot of vagueness in professionalism assessment. Then there are conflicting perceptions. students and faculty may vary different views on what constitutes professional behavior. I mean, this is something which we see every day. I mean, look at the kind of the dresses students use, whether it's a boy or a girl. Many of the teachers may not really like it. Why they are wearing like this? That is because of the generation gap. But and the way they behave, sometimes. Now, this is something which you may have a conflicting perceptions. Cultural and social factors viewed differently across cultures. And I mean, what is seen in your college versus my college may be considered totally different. And most important, self-assessment questionnaires can capture attitudes, but not actually professional behavior. When you start doing an questionnaires, it will tell me my perceptions. It will not tell me my professional behavior. And when somebody starts self-reporting, there's always a risk of bias, you know, because the people start reporting on their own. They may have their own perceptions. Now, when you talk about outcome-based education or competency-based education, I mean, both are similar. Aligning assessment with the goal of producing ethical and compassionate, accountable lives. This is what we have written in our GMR. So, how do you really make it compassionate and ethical and accountable lives? And then, secondly, professional identity formation versus isolated behaviors. And then focus on the formative feedback because it's not a one time behavior. It's the way you look at that particular professional identity and focus on the formative feedback, like how he has developed milestones. There's a need for multi-source and multi-method assessments. So let's look at the assessment methods for professionalism. There are many books, when I started working, there were no books also. Somewhere in 2006 and 2000 plus, I think we started getting this book. One of the best book I feel is David Thomas Town. He was my teacher who wrote this book on measuring medical profession. And I think what he really said that our failure to measure professionalism sends a conflicting message to both students and participants. While we profess and encourage professionalism, we do little to ensure its presence. Very nicely said that time. I think he really put forward the whole idea that unless we start doing it, we'll never be able to really look at these assessments. So let's look at the level of assessments in the Miller's triangle. Now, knowing principles of professionalism, you can easily test, MCQs, SAQs, LAQs, how to behave, what to do, what not to do. You could have case-based discussions. One of the easiest way to do it. Go little higher level, knows how. Describes how to address moral dilemmas. If you have a moral dilemma, how to really address this. So this is where reflections come, narratives come, portfolios come. That is very important. Then if you go slightly higher, that means demonstrating cultural sensitivity. That's the time you are really observed or standardized patient encounter. You could have standardized patients can be used, or you can actually observe the real behavior of a student. But if you want to see how he performs into the system and how he treats the patients, then you need to have multi-source feedback, multi-medical record review processes, outcomes. So at a different level, we need to have a different kind of professional assessment. So the challenges of assessment, I must tell you, are subjective evaluation, difficulty translating values to observers. Somebody has done this and you are putting a value on this. Typically you'll find there is a lot of fight between the behaviors of a young generation versus middle generation. And that is very difficult to put what is value, what they say is right or what you are saying is right. Then lack of standardization. There is no perfect answer many times in professionalism. It is your institutional culture, your own culture, or your colleagues' culture. And summative assessment. Should we include this in summative assessment? I think this is a questionable point. We still have to really working on formative mainly. but few questions can be coming submitted. So when we talk about subjective assessment, evaluation by the faculty, like global ratings, we'll go more details into this, but I'm just giving you an idea. Narrative feedback, allowing to capture context, attitudes, team dynamics, and empathy. Then self-assessment and reflective writing, portfolios, logs, supporting self-awareness and lifelong learning. These are all something which we will discuss more. The first thing what came was checklist. Usually offer a yes or no format. I would done this or not done this. That is usually done in us. Did you really greet the patient or you did not greet the patient? Yes or no? And then you get 1 mark. Now that becomes too kind of sometimes misleading because students are very smart and they do good morning and thank you, but they in between they make a mistake. Now, when you start designing a checklist, the number of checklist items include that are relevant to the assessment's candidate's ability. You look at required tasks, you look at every task should be discrete and observable. Then checklist language should be explicit and unambiguous. Presence of any critical killer item. And of course, you start to know which item to weigh more. These all questions come with the item number 3 has to be given 2 marks or item number 1 has to be given 1 mark. You have to really start really thinking about this. So then came rating skills. Many of you do this rating skills on many apps. How was your journey to buy Uber? Give us 1 to 5, something 1 to 10. That is what we see. Useful for assessing behaviors along a continuum. You look at it whether it was very bad to very good. Suited for more complex tasks and abilities such as organizational skills, establishing rapport, attentiveness to verbal, and it's a more of a reflective rating skill, either self-reporting or when you're doing for somebody, when somebody judging you, how well you really did it. And allowing experts to use their judgment in rating various elements of a task. These are ideal for holistic and global grading. Now, rating scale items should be limited. Don't make it more than 10. I've seen people making 50 rating scales. People get bored and then they start giving answers same way, which are many times, people try to see we are testing his response. So they put similar questions in a different language 3 times. That's a construction issue. But what is important is that don't bore them. Try to be focused and ask one question at a time. Minimize inherent subjectivity of it and relative importance of checklist item and rating scales in each case. So if you compare checklist and global rating, checklists have a binary scale while global ratings have continuous scale. Inter-rater agreement is high because it's a checklist, yes or no, while in global rating it could be moderate. Same thing is the data case reliability, ability to measure content is very high in checklist and ability to measure process is good in the global rate. You can really, if you want to find out uh, whether the system is process is working or not, then I think it's better to do rating skills and validity at higher levels of expertise. So the next thing is how do you assess reflections of our students? Now, Reflect is a tool. There are many tools, but I like this tool. I'm just going to use the examples. Reflect, evaluation for learners, enhance competency. The rubric. Now, for example, when somebody is really writing critical reflection, and how do you evaluate it? So there are ways of really doing it. And you try to look at is it thoughtful, is it critical, has he explored all ideas, values, beliefs, biases, then what frames of reference he has given, meaning of structures he has transformed, and then how he has really attending his emotions, how he's analyzing the whole thing. That matters in all these reflections. Now, the next thing which also you should really know about is workplace based assessment. What we call as WPBA. Now, the best part of WPBA is that it really tests the highest level of skills or anything behavior, which is performance integrated into practice. How well you are doing in day to day life. Now, so you take a lens and start looking at it, direct observation of performance at a workplace, and you also see what is your feedback on performance. And this is much better than a theory question. So this is where you normally would like to do with workplace-based assessments. Now, workplace-based assessment is important because you're documenting the work experience. And how do you really do it? There are clinical encounter parts. You can really see students write down what they have done, what they define, residents can write down. But today, I think this has become like obsolete because of the mobiles and tabs which have come. Previously, students used to have a paper or a card and they used to write on that, and then they show to the teacher and then discuss with him. So one of the way of really doing it abroad. This got never popularized in India because Indian students don't have cards and discussion time. But there are so many other things which became popularized, and I'll try to show you mini CX, which is a 15 minutes examination followed by a good feedback, by the clinician who is watching this examination. Secondly, you could have direct observation of procedures. Somebody is tapping, somebody starting a blood. You could have this. And professionalism mini evaluation exercise. That is something which also is a smaller version which mixes both the things. Then discussion of cases, case-based discussion, chart simulated records. You could really see what it is. And there is something called as a mini peer assessment tool. Empath it is called. That means you take one or two kind of peers and try to see what is their feedback. And lastly, but not the least, is multi-source feedback. And this is very commonly done. You don't only take feedback from the bosses, but you also take from your colleagues, your subordinates, how I'm doing. Am I getting upset too many times? And that getting upset, is it really making impact on the work? So these are all kind of an feedbacks. And of course, every student should have his own portfolio. And this portfolio is not for many times assessment. It is also for your growth of your personal development. So this is mini CX. I think if you really see, I'll try to shift this somewhere. Now mini CX had, you write down name, doctor's name, then you give a feedback about history taking, physical examination, communication skills, then clinical judgment, professionalism, and organizing. And then you normally try to put it on a rating scale. And initially you observe, then you discuss with the student, then you put it on a paper, and then you ask him to go back to further statement. The second is direct observation of procedural skills. What do you mean by that? That they would like to really see you how you do procedure. Thoracic tapping, or you are doing wound suturing. You could observe it 15 minutes and you know how he has taken a suture. Mini pat is like take only one or two your peer assessment and they would look at only 13 or 14 small questions which you have to really take. This was another tool by ANZA which is on more multi-source feedback on paper form. See, this is something which people can really download and give it to people so they can just go on ticking or circle and you get a feedback that yes, you have done it well. So let's go a little higher. There is something called as a global rating scales. This came in International Journal of Medical Education in 2004. So this is a validated tool for assessing competence, which can be adopted for professionals. Often used in simulation-based training. Somebody is doing an CPR. Then you look at this. This is a multi-point scale to score performance with maximum possible scores. I had used few of these scales when I did my work on laparoscopic skills. So you can use this kind of thing. Shows higher inter-rater reliability because this is much better tool than the simple rating skills. So it talks about empathy, talks about humanism. And look at these validity and reliability indexes. They're so good. 0.84 for a social science. These are very good. And secondly, professional relationship and development. How we have developed partnerships with others. Now, this is more relevant in the postgraduate education. Minimal kind of influence on the undergraduate, but I'm sure many centers in the world and India do this very often. So that came portfolios. What is portfolio? It's a digital or physical collection of their clinical, academic, research, and professional experiences, focusing on growth and reflection. It's not only growth, it's also you feel what you have done, and then it's not just listing achievements, but also feeling. It includes self reflection. You write yourself, whatever you have learned or evidence skills. Also write about competencies which you achieve. You also write if you're not very happy, saying that, yeah, I did not learn, I'm going to try it again. And if I succeed, I'll write back. So it gives you pleasure to yourself rather than somebody else. And these are the key components. And today, I think there are electronic portfolios available. They're not very costly. So many students can do it. The best part of portfolio is that it creates assessment of evidence and evidence of learning also. And it is a longitudinal kind of an documentation of your career. If you want to develop, say, later on, any kind of your work, focus work, it can develop it. It can develop your no objection certificates within minutes. So now there are many kind of these e-portfolios which are available. I think you can select one. I think there were some created by institutions also in Pondicherry. I think we should really respect them and allow them to really use this. Then, as I said, critical incidents report is something which we can really use in addition. And if there's an incident, we can really do it. OSPs are objective methods where you can have communication. Reliability increases with checklist and anchored rating list. Then multi-source feedback, 360, and written examinations. Then portfolio and assessment methods like LAMPS and EPSCON. Now you may not really have, many of you may not have heard these words, but I'll try to explain you in next few slides. Now, PESCOM was published in Medical Teacher 2007, and it said Penn State College of Medicine examine, take a questionnaire. It's a questionnaire. It's a professionalism in medical education, the development and validation of a survey instrument to assist students' attitude towards professionalism. That is what this tool is used. So they had multiple kind of thing: accountability, enriching equity, honor and integrity. Then it was developed at Philadelphia and assess the attitudes amongst the medical students, residents, and doctors. It has 36 items. It's a basically rating scale, and it has a good overall Cronbach's alpha. It is a very valid and reliable survey. It also talks about altruism, duty, enrichment. Some of you may be thinking this is something which is off the your campus, but remember, everybody has to be altruistic. Any branch you go, you have to be dutiful. You have to be really having equity and honor what you do. And use of this instrument can be helpful for assessing the current professionalism curriculum, like what you want to use. And if you see, PSCOM has been validated in multiple countries. It is adopted in many cultural contexts, in many curriculums. And at this often juncture, with other methods, if you use OSCE and scenario-based instruments, then it probably gives one of the best assessment of it. And these tools enable educators to identify gaps in what is your professional development. Where do you think they are not able to develop at? And then you create activities to help them to develop those kind of activities. Another post which is there I want to show you is a LAMPS. LAMPS is a valuable tool for assessing medical professionals. And this was also published in 2013. And it talks about self-assessment questionnaire developed to evaluate medical students' attitudes. Again, same thing. And there is seven on duty, accountability of excellence. Negative statements are reverse code to maintain consistency. So LAMP was also validated learners' attitude of medical professionalism scale. Interesting LAMPs. And this was again has a good Cronbach alpha for a social science. And content was confirmed by expert panel because they have to get peer assessment, ensuring the tool's internal reliability and it can be implemented to measure baseline professionalism. So let's take some scenarios, now that we have 15 minutes, 15, 20 minutes more. I think we will try to do this. So let's take first scenario of respect and patient dignity. A final year MBBS student is examining an elderly patient in a busy ward. That's what our wards are. Our wards are very crowded, busy. The consultant and team, there's a doctor, professor, and associate professor, arrive and start discussing the case loudly at bedside, ignoring the patient discomfort and not drawing the curtain. Now, those four lines are most important. So look at those various behaviors. So student pauses the discussion, suddenly opens the curtain, introduces the team, explains briefly, he closes the curtain, introduces the team, and explains briefly to the patient what will be discussed before proceeding. A simple act. What boss did not do, I think the student did it in a very quietly without really ignoring the boss. You don't have to tell boss that close the curtain and all. You yourself close the curtain. And he would say, if these doctors have come, they will discuss about you and give you the best treatment. Now, how do you assess this? Now, this can be assessed through checklist, like respecting patient, communicating clearly, advocating for patient comfort. These all can be really done with TMX, mini CX, narrative comments. This second is honesty and accountability. During a night shift, the resident realizes that a dose of insulin was delayed by 2 hours because they misread the chart. The patient is stable, no harm done. That is very important. The resident still informs the consultant, documents the delay, and speaks to patient family and explaining what has happened and what will be done to prevent. Now, see, this is where the honesty and accountability come. When you have many residents, as a boss, I always feel that some of the residents do not tell you the truth. If you're a clinician and you're working somewhere, we have to really dig from them sometimes, ask for patients' parameters, watch them, talk to them, then they will give. But if you are really honest, you would still do it and inform the patient, and you will see that you take over the work. So, how do you assess this? Now, this is where the critical incidents analysis comes into picture. You have missed the insulin. Now, many times what happens next day morning round, you would like to really discuss this critical incidents. And you can put it in residence logbook with faculty global rating and say that in spite of 2 hours delay, which could have has happened, patients have been angry or likely to get angry, then you are really judging it. So faculty can really put it, and these are done with critical incidents reporting, faculty global rating and reflection, and then you write it down either in portfolio sheets or your own reflective sheets about this particular resident. This is mainly for residents, I think these tools are which are done for honesty and accountability. The third is professionalism and social media. Last few years, we have been seeing this very often. A group of students create a WhatsApp group to share cases and make exam tips. One day, a member posts a photograph of a patient's wound taken in the ward without consent and with identifiers viable. He may be having something. You maybe put his whole face. You may put his legs with things and following by joking comments, worryingly joking comments. Another student privately messages the sender, explains why this breaches confidentiality and requests deletion and suggests raising social media professionalism in the next class. Very interesting And we have seen these kind of things violated many times everywhere. I've seen doctors discussing patients' reports and patient cases while traveling in a lift. Now that is unprofessional. You should have seen that if somebody is doing this, that means it's breaching the confidentiality. In fact, in our hospital's lift, we have put typical charts. Don't really discuss patients' reports because they always say that somebody is listening to you. Now, how do you assess this ability? Now, this is usually done either by OSCE or ATCOM station. You make students discuss this. Let them come out with their perceptions. Let them understand their consequences. And rating skills can include maintain confidentiality, whether he did it into 1 to 5, where you can give him 5 star or 4 star or something. And therefore manages peer behavior properly. Is he behaving with your colleagues well? Are you bullying them? Many times I've seen there's a young shy girl in a batch of 10 people. I think they bully her so much that she keeps quiet. But I think we should really see how do we manage the peer behavior. And this can be done with professionalism checklist or case scenarios. Another one I would like to say is responding to professional lapse. So honesty, how do you really do it? A second year resident frequently arrives late to small group sessions and one signs attendance for a friend. Now, facilitator documents the pattern, meets the student to explore results, clarifies expectations, and agrees on the remediation plan that includes punctuality tracking and a reflective. Now, I have seen this many times. People are signing for each other, because you have come there. How do you assess this? This assessment is longitudinal. Repeated global ratings about punctuality, reliability, honest. If you start doing this, then you will find you can really assess this professional lapse. As well as faculty narratives component, review the students' reflection that can be included in professionalism portfolio. Let's take last example. On rounds, nurse expresses concern that early discharge may be unsafe because home support is inadequate. Very common thing in a public hospital that we send patients little early because they are overcrowded, we don't have beds, and their home support is not adequate. The intern listens, reassesses the patient with the nurse, discusses the social media contacts with the team, and advocates a delayed discharge until home care is arranged. Now, this may not be feasible all the time. It may be only feasible in some cases for some period of time. But this is where the advocacy comes into picture. Now, this can be done through 360 degrees feedback. You take multiple people, supervising doctor, nurse, everybody, and they can give you a focused workplace basis. So let's come to the next point, that is humanities and ATCOM. We have introduced humanities in India many places, and ATCOM has been introduced. So what is its effect on professionalism? Now, some students may never witness such a role model. Humanities is something which promotes competence, and this was in UCMS, British Medical Journal 2019. That medical students could be utilized through exposure to humanities to explicitly develop these skills. We have a wonderful department of humanities at KM Hospital, and it's a very active department. We have so many activities done every year. We have a workshop on resilience, we have panel capture, then we have human library, where students tell each other. Then it also tells you what does it need to be patient. This was the ATCOM module. And film shows, we have called many stalwarts to present their paper at the same time also discuss, like the movies like Anandi Joshi, Anandi Gopal they call. Wonderful movie. It can really tell you, my sister's keeper, where the sister doesn't want to donate bone marrow because she's sick. Some of these are very interesting films. So what were challenges in ATCOM? It was an additional curriculum, working after regular classes, extra effort by teachers and students, as well as funding. What could have been achieved would be achieved. In spite of that, we could really now introduce humanities in a big way. active student participation, and I have always published many articles on humanities, and this is our annual conference on humanities. So students only take responsibility and they present the whole thing. And we also send our UGs for teaching in slum children, and they are sharing their experiences in this. There's a commitment of interns and students. They go to Sevangpur for 1 week for nation, in deep village, they help people. So now what has happened, WHO this year has recommended that humanity should be part of every college. So I would say that if you don't have a humanity cell, I think it's time you create one. And we need to take forward and convince medical educators of how literature, visual arts, and history may help students to understand and widen their vision. So it's not a cultural curiosity. They will help to train more empathetic physicians. And that is what they say. So when we started developing ATCOM, we tried to give some assessment method, direct observation. It was mainly for formative, OSCEs, reflective portfolios, peer assessment, logbooks, Viva, and behavioral focus. Basically, we wanted to have feedback was main thing. Trained assessors. Basically, we wanted to train the educators to look at the assessment of ethics, attitude, and communication. Then integrate this whole curriculum into regular curriculum. Take away the portions which are not really necessary. And of course, we have multiple observers while doing this. Now, ATCOM got integrated quite well. There are so many centers who are doing this well, and it can be, there are many methods which you can really do it in MBBS. Maybe there are only 8 or 10 marks, but it is still a worth topic. For, hello, can you hear me? So mandatory inclusion of professionalism, we have said in NMC, encourage remediation modules. That's what we said. And faculty development is important. So we did, and if you see, ATCOM had a tremendous response. ATCOM really brought so much of response to this particular system. People got books, people got assessment methods, people got videos. There are so many questions. So I thought ATCOM was successfully integrated. There was a whole conference on ATCOM. I was really surprised. I attended one conference by Grace in Pondicherry, which was totally on ATCOM. So the main challenge what we have is when you're trying to assess a professionalism, we have to integrate with the curriculum, our day-to-day curriculum. And how do you do this? So that's our challenge. So it has to be integrated continuous, mainly formative, but some part in summative. Assessment, communication, ATCOM has few marks, 5%, not really more than that. Use a spiral curriculum. Begin with a strong cognitive base and then build upon it with the appropriate learning and assessment activities as the student progresses. Provide explicit and implicit teaching. You should have good role models. At the same time, informal or hidden curricula, role modeling and institutional culture. Bring it in your institutional culture and utilize diverse assessment tools. Make it fun. It should be a fun making for students. Now, if you look at current evidence and best practices, there are recently systematic reviews suggest a combination of methods enhances validity, not only one method. Longitudinal multimodal assessment linked to professional identity formation and sustainable learning. And of course, you document, reflect, and regular feedback. So this was a very nice review which came in 20 years, systematic review in 2025. The medical professionalism education, a systematic review of interventions, outcome, and sustainability. Very nice review, which I think all of you could really read, really available. So what does it say? That assessment verified, you have quantitative questionnaires, which I showed, narrative comment, it's the qualitative component, focus groups, interviews. If you want to test empathy and compassion, it could be self-reporting questionnaire, behavioral assessment, standardized patient encounters, observed and patient reported outcome measures. You know, you have to really, there are so many scores which are available for empathy. So what is challenges in institutional and systemic framework? We have many times negative role models. I feel in a medical college, there are some models or role model which always dissuade you to start passing useless comments. And in an institution, the students get confused. The faculty, there are some good faculty which they follow, but students are also smart. Over a period of time, they realize who is a person who is progressive and positive and who is a negative role model. Then workplace pressures. We get too much of time pressures while working. We are competing responsibilities, which sometimes people cut corners. What is called as a deviation gets normalized. That is a wonderful concept, and you'll find in a hospital many times people deviate from standard practices. And then over a period of time, that becomes a routine. And that may not be the right way to do it. But people cut corners. Misuse as a disciplinary tool. Professionalism assessments can be used to label and sanction individuals rather than promote learning, which is counterproductive. Instead of that, you try to make them internalize these behaviors. And there's a lack of standardized framework, because there is no standardized framework. Sometimes I've seen even teachers get confused. So, what you have to really understand, you have to understand the goal rather than methods are useful. I'm not saying no, but more important that there has to be a standardized framework, whether he has achieved this at that particular level, achieved this or on that level. So, do it at a periodic level. So, what is the way forward in all this? Now, this was another good paper I read in Made It Publish. Where, when, and how should we assess professionalism in undergraduate medical education? Practical tips from an international conference roundtable discussion. It was a consensus kind of a discussion. It's a fairly recent paper in 2024. It asked three questions to the experts. What method should we use to assess professionalism? When in the year we should use assess professionalism? And where in career should we assess professionalism? Very interesting question. Three questions. And they give this systematic view of professionalism, physician interactions with care team, and all this. So these experts give few key messages. Professionalism required to be formalized and visible. Previously it was hidden. So first thing they said that professionalism now needs to be formalized and visible instead of hidden. And they say more formative than some summit. So I think we are right on the right track in India to introduce this. Expectations, standards, assessment pathways for professionalism must be fully disclosed and readily accessible to learners and educators. We have created books, but we need to create more books. And knowledge kind of a dissemination is important. And educators need support these developed skills in assessment of professionalism. I think this is another task. It's not so easy. Then longitudinal assessment techniques are required. It's not one time, but as I said, you have to have longitudinal assessment techniques like portfolios. Then escalation of professionalism issues require a clear, transparent framework, honesty and transparency. And professionalism assessment is an essential component of a medical. Remember that all over the world, there are countries and countries where I've seen professionalism given so much of importance. It's only in our country, because of 27 or 30 states and a large wisdom, we tried to change this. To summarize, the attitudes are important for medical professionals. Attitudes are imbibed by students by observing parents, teachers, and role models. Attitudes need to be imbibed through formal, informal training and hidden curriculums. Formative, formal, and informal assessment is necessary, in a formative setting. So what we really need to do, all of us, is implement it in medical college. We need a team, collaboration, and trust. So we are what we repeatedly do. Excellence then is not an act, but a habit. These are some of the references which I already have shared, and I'm sure you will share it to others. So thank you so much, and I can take some questions if you are ready.